Okay, 1, 2, 3, 4. Just 6 students here. So maybe we'll wait for another 2 more minutes and then we'll start, okay? But in case you have any questions from the previous lecture, you can always ask. Okay, maybe we should start. Now, so today we will be doing the macro minerals, okay, instead of the list that you receive, which is supposed to be the trace. But I always do the macro before we do the trace elements. Okay, now, so what we're going to cover will be just a few of them. And some will be in much greater detail than the others, okay? So what you will see in the initial several slides, I'm just highlighting to you some of the pertinent points on sodium and potassium, okay? Now, then we will move on to the more detailed ones, okay? So we will do the calcium, and then we will do vitamin D, which is very much related to calcium metabolism. And then we'll talk about magnesium, okay? Just in case you just come in, if you have the ethical approval, then you may come and pick it up, okay? So in case you are expecting it, some of the students have already picked up the approval. So in case you, what's your name? Okay. Okay, now, so this is the learning outcome for the macro, okay? A bit detailed, but basically what I expect you to do is to be able to identify some of the important food sources, which is of course easy. Then we'll talk about, in general, the absorption of the various macro minerals, and then we will spend quite a bit of time talking about the relationship between vitamin D and calcium, which you presumably may have learned in some of your nutrition classes. Presumably, we will be doing it a bit more detail, okay? And then we will talk about the assessment methods, talk about the risk of disease related to the deficiency and or too much, okay? And so that's what we're going to plan to do, okay? Now, for the second slide, this is just a outline for you so that you know how we more or less define what is macro and what is micro. Okay, so when we say micro mineral, then we usually refer them to as trace elements. Okay, so this is more or less the line that separates the macro and the micro. And as indicated here, macro mineral usually are those which are present in our body for 60 kg person, 5 gram or more. Okay, so what you see here is, in this case, say for example, magnesium, which is the last of the macro, and your body has something like 30 gram. Okay, then you come to the micro, and you can see iron, you will have much less. So I would like you to know, okay, which are the macro. Once you remember the macro, then the remaining would be the micro. Okay. Now, as I said, we'll just spend a little bit time talking about sodium and potassium. Okay, and of course, sodium is essential, and there are significant interactions between sodium, calcium, potassium, which obviously will have big implications on our body health. Say, for example, in particular, your blood pressure. And so what we're going to do is basically highlight to you some of the relevant points. Now, an important thing for you to remember is sodium is the principal cation. Cation means it carries the positive charge, extracellular. Okay, so if you think in terms of extra and intracellular, sodium is always the principal cation outside the cell. Okay. Now, so when we say sodium, we always worry about too much sodium, which in fact is true, because in most of the population, sodium intake is very much higher than what is needed. So this is the so-called general definition for hypertension, as outlined by Center for Disease Control. So if your diastolic and systolic blood pressure are at this category, then you are considered to be a elevated level of blood pressure, and then you will be stage 1 hypertension if your diastolic blood pressure is greater than 80, and or the systolic is greater than 130. Now, of course, there are many reasons for you to have high blood pressure. I'm just highlighting a couple of here, which are more or less relevant to quote the characteristic of sodium being a major principal cation extracellularly. Okay, so you will have a high blood pressure when you have increased blood volume due to increase in sodium retention. When you retain more sodium, as sodium is extracellular, as I said, so you will draw you will draw water into the system, and therefore you will have an increase in the blood pressure. The other one would, of course, being the constriction of the blood vessels, which create increase in blood pressure due to maybe the cholesterol deposits. Now, so hypertension is a risk factor, and it's listed here, so I'm not going to go into detail. Sodium and potassium has significant interaction, okay? And something that if you already know, that's good. If you forget already, this is a reminder. So if you are potassium depleted, then your pressure goes up. When you give potassium or added potassium to the diet, your blood pressure goes down. Potassium is counteracting sodium in a significant way. Now, so what you see here, population with low potassium intake are always associated with a high prevalence for hypertension and stroke. Now, if we look at the AI for sodium and potassium, okay, for adequate intake generally is 1500 milligram or 1.5 gram. WHO would say 2 grams, upper level 2.3, and of course, in general, majority of us are taking in more than 2.3. Some studies in China, the average intake is maybe 5 or 6 grams a day. And then potassium, okay? Now, you can see that the AI or the adequate intake for now, at least with the respect to the US DRI, is 1.5 versus 4.7 gram, okay? Now, but you can see here that the WHO as well as the European authorities are in fact putting it at a lower level, okay? And I want you to remember that because we will come back to this point in the subsequent slides. Okay, so the issues will be, well, we are taking in too much sodium, not taking in adequate amount of potassium, okay? And then there's significant sodium-potassium interaction. And what about the dietary alternative, okay? Why we end up always having too much sodium and too little potassium is because if we are eating a significant proportion of our food in the so-called processed form, then the processing would tend to decrease the amount of potassium and, relatively speaking, increase the proportion of sodium. Potassium, as I said, is a important electrolyte, okay, and it serves one of major intracellular cation, okay. Now, sodium and potassium are excreted in a fairly effective way. Usually, 80 to 90% of the ingested sodium or potassium are excreted in the urine. And so, very often, urinary sodium or urinary potassium concentration are used as a marker to estimate, okay, how much sodium is being ingested, okay? Now, so if you look at this diagram, this is just to give you an idea what will be the so-called potassium-rich foods. I'm not going to spend time on it, okay? But highlight to you that in Hong Kong, we do not have a lot of availability with the low sodium salt, okay? So actually, in the past few years, I only spotted some more expensive supermarket to carry the low sodium salt. But recently, I saw PARKnSHOP also carries this brand. Now, what you see here is, I just show you the comparison. If you take 5 grams of normal salt, okay, then it contains 85 millimole sodium, okay? This is the low salt, and if you take 5 grams of low salt, and this is the relative composition of sodium and potassium. So 5 grams would correspond to 28, okay? So you're talking about if same amount, 28 versus 85, okay? So it is a, yeah. Good point. Is quote, not as salty taste. And in fact, potassium actually have a little bit of bitter aftertaste. But it's a matter of, again, whether you are acquiring that taste sensation, okay? And of course, if you think real salty is important, then of course you would not take this one. On the other hand, well, I took low salt many years ago, and we don't feel that there's much of a big difference. Depending on usually how much salt you put in. If you are putting the salt in cooking, usually you don't notice that. But if you are putting the salt on your food and then take it in, you may notice the difference. Again, depending on your sensitivity of your taste bud. But you can see the difference, okay? It's roughly 1/3, okay, of the sodium that you take in. And at the same time, then you're replacing the sodium with the potassium. As I said, normally, majority of the population is taking too much sodium, too little potassium. So if you replace the salt, okay, say with this one, for example, this is not the only brand, okay, there are, I think there are more than one brand. Then you effectively can do both. That is to reduce the sodium and then at the same time, increase potassium intake. Okay, now you probably in your nutrition course, you probably have learned this term DASH, right? So dietary approach to stop hypertension. And of course, that will be a general recommendation for increase in vegetable intake and then decrease in the processing food, increase in fruits, and so on. Now, so this is just a study showing you what will be the blood pressure response to low sodium intervention. Okay, just if you decrease your sodium. So you can see that your systolic and diastolic will go down. Now, this is in terms of meter of mercury. Okay. Now, so, and in fact, these are considered to be clinically significant. So 5.5 and 2.8. So this is the systolic and diastolic. I won't go into this one and then highlight here. What if you increase your potassium intake? So through supplementation. So you decrease it by 3.5 and 1.4. Now, of course, you see that potassium increase, the effect would be less than decrease in sodium. Okay, so ideally, the most effective way is to reduce your sodium and then increase your potassium. But to some extent, okay, this is a fairly recent meta-analysis, okay? We won't go into the detail, but the whole point is that, and I have highlighted here, a U-shaped relationship, okay, in terms of sodium and potassium intake and how it would be affecting your blood pressure. So in fact, you need a good amount of potassium, but too much potassium actually will also lead to an increase in blood pressure. Okay, so that's the whole point. And if you remember what I mentioned just a few minutes ago here, that the AI, okay, for World Health Organization and that of the European Authority is around 3.5, whereas in the United States it's still 4.7. Okay, so they decrease this because they think that too much potassium may not necessarily be good, and therefore it is not good idea to recommend people to, or to recommend a high AI, okay, adequate intake. So presumably 3.5 gram, they think will be good enough. And if you have time, you can look at the this, and in fact you can get the paper, and that 3.5 gram, which corresponds to about 90 millimole, is about the sort of the point where further intake will lead to adverse effect on blood pressure. Okay, so my key point is that you would like to decrease your sodium intake. You want to have an adequate intake of potassium, but too much potassium, actually, based on recent data, are not necessarily good for you. Okay. Now, so what we're going to do is to leave this and then go to calcium. So majority of the time we'll talk about calcium and vitamin D. Okay. So we'll talk about calcium first, then we'll talk about vitamin D, and then we'll talk about magnesium, because they are more or less interrelated. Okay, so calcium, of course, most of the calcium will be in your bone, okay? And the important aspect is that they form crystalline structures, which are generally referred to as hydroxyapatite, and that is providing you with the strength and the structure for your bone, okay? So when we say calcium itself, there are many functions of calcium, okay? And of course, one of the most important one from an extracellular viewpoint is that it is involved in blood clotting. So you need calcium to mediate the blood clotting cascade reaction. And intracellularly, okay, calcium is important or required for muscle construction. Calcium is important for muscle contraction. And then at the end, when we talk about magnesium, magnesium is doing the reverse. Magnesium is important for relaxation, okay? So calcium and magnesium are opposite in terms of function when it comes to muscle contraction and relaxation. Of course, we need calcium for nerve impulses, hormone secretion, enzyme activation, etc. Okay, there are a whole range of diseases that are related to calcium. Okay, and then we will highlight some of the issues here later on as we move along. So calcium, this is the food diagram. Okay, and I won't go into detail in terms of which food. I'm sure you are quite familiar with it. Okay, now, so if we look at the RDA, so we are talking about, depending on which country you adopt in terms of the recommendation, is somewhere around between 1,000, that is per milligram, to 1.2, okay, a gram. Okay. Now, so of course, from a Western diet point of view, the major calcium source will be dairy, okay, milk, yogurt, cheese, okay. And from the viewpoint of the Asian community, it will be the bean curd and tofu and the related foods. But there are also, of course, certain other foods which are, relatively speaking, high in calcium as well. Now, one of the aspects is, well, I can get calcium from mineral water. Okay, so different mineral water actually has different concentration. I'm just highlighting to you some of the popular brands. Okay. And so if you look at calcium, magnesium, potassium, and sodium, and I include sodium here because, of course, you don't want to take in too much sodium while you are drinking the mineral water, hoping that you will get calcium, okay? So these are, relatively speaking, concentration of the minerals in a 1 liter water. So dB, of course, is the daily value. So you can see that some brands hit a level of 35, okay, per 1 liter of mineral water, okay. Whereas this one, 10% daily value, but then sodium is 17% daily value. So again, you know, when you are talking about selection, then you have to be fairly careful. So this one, for example, okay, 20% versus 2%, okay. So different brands has different, depending on where they source the water, then they may have different level of minerals that you want, or that minerals that you don't want. Again, don't memorize this number. Okay, you're not going to. I'm not going to ask you in the examination for the concentration. This is just for your information. Okay, and of course, you probably have learned in your nutrition. Okay, in terms of the impact of absorption. So different foods will have different bioavailability, and so some which tends to have a low absorption efficiency, whereas the others will have a relatively much higher absorption efficiency. So this is just a summary of interactions. Okay, so nutrients that enhance calcium absorption. Of course, vitamin D is what we're going to talk about. And then nutrients that will increase calcium excretion, which is also important because in and out. So we want to make sure that we have adequate intake, but also if in your diet there are factors that will increase calcium excretion, that also may play a role. Excuse me. Now, again, these are established facts. For example, that sodium, protein, caffeine will increase calcium excretion. But depending on the level of intake, and usually from a normal dietary standpoint, okay, if you are taking in 1 or 2 cups of coffee or a reasonable amount of protein, it's not going to have a significant impact on the calcium excretion. Okay. So although these are established facts, but from a real dietary standpoint, the impact is not that big, okay, as compared to your dietary intake, okay. Then you have the substances in the food that will hinder calcium absorption, okay. So these are some of the aspects. Phytate, of course, fibers, oxalate, these are things that will obviously impact your calcium absorption. Now, so what you see here is a very simple diagram, okay, that shows you the 3 major organs that contribute to the blood calcium concentration. Now, most of the calcium will be in the bone, as we said. Where it comes from will be from your diet, okay, which obviously will be your gastrointestinal tract. And then excretion, this is your kidney, okay. The degree of excretion and ability to reabsorb calcium back will then play roles in your overall body calcium concentration in the blood. Basically, our blood calcium concentration will be controlled rather tightly, okay? And that, again, we will talk about that in a minute. Okay, so the resting concentration of calcium in a cytoplasm is normally maintained at a certain level, Okay, so don't worry about this value because I'm not going to ask you, how much this is. Now, this level is many fold lower than the typical extracellular concentration. Okay. This low concentration is maintained through calcium actively pumped from the cytosol to the extracellular space into the endoplasmic reticulum and blah, blah, blah. Now, there are many suborganelles, okay, that will control the intracellular concentration of calcium, as indicated here, for example, ER and the mitochondria. Because the amount of calcium inside the cell, in the cytoplasm, will significantly affect a lot of enzyme activity and also the protein channels that will allow in and out of a lot of other substances. Now, so what you see here is a diagram. And if we look at it here, okay, so age from 0 to 90 years old, and what you see will be the so-called, this is the range, in terms of the relatively speaking, the blood calcium level over time. Okay, so you can see that relatively speaking, it is regulated or controlled at a relatively stable level. Now, so the diagram on this side, okay, shows you a composite way to show you how you increase or how you decrease the calcium level, okay, in the blood, okay, and under normal conditions, your calcium will be regulated at around, say, 10 milligram per deciliter. And that is what we refer to as the normal calcium level, okay? Now, so this is the 10 here, okay? So these are the things that will increase, and this will be the events that will decrease the calcium level. Now, we will go into another diagram, which will provide you with a better picture, okay? So this is just a summary diagram to highlight to you that the homeostasis is more or less achieved through this cycle, okay, that will maintain your blood calcium concentration at around 10 milligram per deciliter. Calcium, as mentioned, plays many different biological roles, okay, in your bone, in your teeth, contraction, okay, muscle as well as your heart, hormone secretions, coagulation, neurotransmission, etc. Now, from a biochemical viewpoint, then I would like you to at least have some idea in terms of a few important enzymes that are calcium or calmodulin related. Calmodulin, as you can see in the subsequent slide, is a protein which is calcium binding, okay? And it plays a major role in a lot of biological systems. Now, you can remember, or you probably remember a number of these enzymes, but for easiness, then I just highlight these three, which will be shown in the next slide. But all these, and plus many more, are considered to be calcium dependent. So we would just talk about cyclic nucleotide phosphodiesterase, phospholipid A2, and then pyruvate carboxylase. So this is just the diagram, a cartoon diagram, for the protein, which is very much calcium dependent, and it serves as a important regulator for many physiological functions. So when calcium binds to the calmodulin, the protein, it will change the structure, which will then become active to play roles in different biological effects. So these are the reactions or diagrams for the field of the enzymes that I'm referring to. So the first one is phospholipase A2. Now, hopefully you remember in your biochemistry, phospholipids will be what? Will be your glycerol backbone with fatty acid, okay, and then of course phosphate, which will be here. Now, then hopefully you remember, or it has been mentioned by your in other class, in the phospholipids, okay, generally speaking, is the SN2 carbon, or the carbon in the middle, that will be esterified with the unsaturated fatty acid. Okay, you know that or you don't know that? Yes? No? No. Okay, let me just repeat it. You know triglyceride. You know phospholipids. Phospholipids are embedded in your cell membrane. Okay. Now, the phospholipid has a glycerol backbone, 3 carbon. Okay. Carbon 1, carbon 2, carbon 3. But in general, it is the carbon 2 that is esterified with unsaturated fatty acid. You can see that, say here, saturated fat. Here, also not unsaturated fat. This is attached with the phosphate anyway. Usually, it is an unsaturated fatty acid that is esterified to the middle carbon, SN2. Now, there are many enzymes to cut the phospholipids. Okay, we just focus on A2, which is responsible for hydrolyzing the fatty acid in the SN2 position. Okay, why I emphasize this is because when you release this fatty acid, if it happens to be a arachidonic acid or a omega-3, then they will be the precursor for making a variety of highly reactive chemicals, such as prostaglandins, leukotrienes, etc. Okay. In fact, arriving from arachidonic acid and SN3, omega-3 fatty acid, there are something like 50, 60, 70 different compounds that can be generated from there, which are all biologically active. But when the fatty acid is still esterified to the phospholipids, then they won't be converting to the eicosanoids. Only when they are free, then they will be added on by different enzymes. Okay, so the phospholipase A2 is responsible for hydrolyzing this, freeing this fatty acid, and that this fatty acid will be added on by a variety of enzymes, other enzymes, to make the eicosanoids. Okay, this one, making cyclic AMP, of course, cyclic AMP is the second messenger, cellular second messenger. Cyclic AMP can be degraded, okay, and that is by phosphodiesterase. So the enzyme is calcium dependent. And then I say here, inhibited by caffeine. And this is one of the effects of caffeine. caffeine inhibit this, therefore increase cyclic AMP. And then the other reaction will be what we talked about just last week, not last week, Tuesday. And that is the biotin-dependent enzyme pyruvate carboxylase, okay? And that is converting pyruvate to oxaloacetate. And in this case, this whole reaction is calcium dependent as well as magnesium dependent and so on. So again, very important reactions. Now, so we will then start to move into what calcium relates to bone and the various bone problem that would eventually link to vitamin D. I'm sure you have encountered this to some degree in your nutrition course, right? Yes or no? Okay. Now, so these are just the definition of the relevant materials. What I want to highlight to you will be the two terminologies that you may or may not encounter. I'm sure you had seen osteoporosis before, okay? And osteoblast and osteoclast. Have you encountered these two in your previous lecture? No. Okay. Now, so what I want to, and we will talk about this too, osteoblast and osteoclast are two types of cells which more or less has opposite effect. Osteoblasts are responsible for making bone tissues. Osteoclasts will be the cells that are responsible for breaking down. So this is for building, this is for tearing down. Okay, so osteoblast and osteoclast. Now, the activity of these two will directly affect your bone structure and therefore impact on osteoporosis, which we'll talk about in a minute, okay? Now, of course, rickets is the typical situation in which when you have calcium and or vitamin D deficiency, then you, or if it happens in children, then you will have the rickets, okay? Top, when we say mineralization, is the process which calcium, phosphorus, and other minerals, which then will crystallize on a collagen matrix to form the bone and harden the bone. So when we say mineralization, then we usually refers to the activity related to osteoblast, okay, which make bone tissue. Now, you will see another term which is called demineralization, or we call resorption, and that is the opposite of mineralization, and that will be the role of the osteoclast, and we will show it to you in the next few slides. Okay, so the typical situation of vitamin, calcium and vitamin problem in rickets will be bowleg, okay, so because of the softening of the bone tissues, which will not be able to carry the weight on the upper body, and so you have bowleg, and also then the closure of the fontanelle, and that is a opening space here, but we're just showing it to you. You don't have to remember it in detail. So what you see here is just some description of the bone, which again, I don't need you to memorize it, okay? But some terms are important. For example, later on, you will see this term hydroxyapatite. So I want you to remember the formula, okay? You will see this formula again and again. Calcium 10 phosphate 6 OH 2. Okay. Now, so bone development and disintegration. So that means making of bone and breaking down of bone. Okay. Bone tissues is dense connective tissues that give rigidity. 70% by weight of human bone is a modified form of hydroxyapatite, or known as bone mineral. Okay. Now, in general, we talk about two types of bone: cortical bone and trabecular bone. And one is what we call at the outer shell, and the other one is more at the inside. And what you see will be, which is shown in the next diagram. So this is just a cartoon structure of the structure of the hydroxyapatite, depending on when you take this picture or this drawing. The more recent one will have a structure a little bit different from the other one. So again, this is just to show you, and you don't need to memorize it. But I want you to remember this: calcium 10 phosphate 6 OH2. Now, why we want to remember that is because later on, when we talk about fluoride, then it is the fluoride that is going to replace some of the OH. Okay, so that's why I want you to remember this formula. So up to 50% by volume and 70% by weight of human bone is modified form of hydroxyapatite. Okay. Now, so when we say spongy bone or compact bone, which also have the other name, cortical bone and trabecular bone. So cortical bone will be referring to the outer part if you are looking at this particular bone, and then the trabecular one, which is the spongy one, will be the here. Now, usually when we say osteoporosis, we are referring to the problem associated more with the spongy bone. We'll talk about that in a minute. Now, this diagram, again, I don't need you to memorize and or draw it. I just want to show you, okay, that this is the a typical bone, okay? Then at both ends, okay, we call it epiphysis, okay? Then next to it, we have this epiphyseal plate. Why I mention this is a fairly important location where elongation takes place. So babies, toddler, children, teenager, they have longitudinal growth in terms of the bone, and getting taller and taller is more or less due to the activity here. After puberty, the epiphyseal plate will close, will seal off, and you will not gain height or bone length further. Okay? So don't trust people saying that I can help you increase your height by blah, 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 because this is a physiological event that after puberty, generally speaking, this is sealed off. So you won't get any bone elongation, okay? You won't get any bone elongation. Now, so remember, I say there are two opposing processes. One is laying down of the bone material. The other one is breaking down of the bone materials. This happens all the time, whether you are a baby or an old person. But the relative rate will be different. Okay? So we say this process of breaking down the bone and rebuilding the bone is called remodeling. And this remodeling is an ongoing physiological process that happens, as I said, whether you are a baby or elderly. Only that a baby, the laying down of the bone is much faster than that of breaking down of the bone, whereas for people who are older, then the breaking down of the bone will be faster than that of the laying down of the bone. Okay, so what you see here is just a cartoon diagram showing you the two types of cells, okay, which are responsible for breaking down of the bone and laying down of the bone. Okay, so as I said, osteoclasts are responsible for breaking down of your bone material. And we say this is a resorption process, okay? Not absorption, don't mix it up with absorption. Huh? Resorption refers to breaking down of the bone material, okay? Now, after the activity of the osteoclast, then you will have the activity of the osteoblast, which will then start to laying down of the bone materials and then mineralization occurs. So this process, as I said, is always going, whether it is you or me, anytime, only that, okay, in certain age group, you have osteoblast activity higher. In other age group, you have osteoclast activity higher. So remodeling of the bone is an ongoing process, okay? So what you see here is, as indicated here, physiological state, which is in which bone resorption equals bone formation. So you have osteoblast activity, more or less same as the osteoclast activity, whereas in osteoporosis, you have bone resorption activity greater than that of bone formation. And at the end, then you are losing your bone matrix in your mineral, and that is the consequences of osteoporosis. Now, so a bit more detail of the two types of cells. So this is something that I want you to remember. A lot of the information about nutrition in the general nutrition you may learn it earlier. So this calcium cells or this bone cells may be of new information to you, so it will be important for you to, as new information to pick up. So osteoblast and osteoclast, okay? Two types of cells. One is laying down, the other one is breaking up, okay? Now, I'm just highlighting some of the relevant information. So osteoblast, okay, contains something called alkaline phosphatase. This is one of the enzymes. Of course, it has many enzymes. And its role is to create a desirable calcium and inorganic phosphorus concentration for mineralization, okay? So this mineralization will lead to interaction with the collagen, okay, which eventually will form the bone tissues, okay? Now, then you will have something called osteoclast, which is shown in here, this diagram, okay? And one of the enzymes that it contains is carbonic anhydrase. Now, carbonic anhydrase is a very common enzyme that occurs in many parts of your body, including your lung, because this is the enzyme that is responsible for helping you to do the acid-base balance when you're breathing in, breathing out etc. But in the bone cell in here, the activity of this enzyme, carbonic anhydrase, okay, as shown in here, will carry out the reaction, although this is always a reversible reaction. But in general, it tends to go this way, and then creating an environment which will lower the acidity or lower the pH, and therefore increasing the acidity of the environment, okay, and therefore help to dissolve the bone mineral content, okay. I say osteoclasts are cells in the bone that breaks down the bone. How do you break down the bone? And one of the aspects is that you create a acidic environment to dissolve that mineral complex. And that is the job of the enzyme, which is present in this type of cell, okay? So osteoclast activity will lower pH, which helps dissolve bone materials, okay? So this is what you see here, and I say the acidic environment also has another effect. See later slide. So we'll talk about that in a minute. Okay. So I just want you to have a perspective on the role of osteoblast, how it makes mineralization, and that is because it contains an enzyme, alkaline phosphatase, which is important to create a desirable concentration for calcium, iron, and inorganic phosphate. Whereas osteoclasts will have the enzyme carbonic anhydrase, which will then lower the pH environment and therefore help dissolving the mineral complex. Okay. So if you remember, we say our bone, the calcium usually are occurring in the form of hydroxyapatite in this particular formula, right? Now, so the two types of cell, one in green, the other one in red, osteoblast is to help to convert, okay, the amorphous calcium phosphate into the crystalline structure, whereas the acidic environment will help to break it down and then release the calcium and phosphorus. Okay, so that is primarily the way, okay, which we control the bone environment. So what you see here, as I mentioned, alkaline phosphatase is to create the desirable calcium phosphorus concentration for the osteoblast to lay down the hydroxyapatite. Whereas the red diagram, the red arrow will be the osteoclast, which has the carbonic anhydrase, and of course, many other biological activities, but decreasing the pH environment will help to break down the calcium complex, calcium phosphate complex. Now, then comes to yet another very important point. And that is, now I'm introducing to you another protein. So this is not a cell, this is a protein, osteocalcin. So anything start with the word osteo, refer to bone, okay? Osteocalcin is a non-collagenous protein found in bone and dentin, secreted by osteoblast. So remember, osteoblast is what? It's the cell that lay down bone. So when it's lay down bone, it also make this protein, okay, around the time of the onset of the hydroxyapatite deposit. So this protein is important for the formation of the hydroxyapatite complex. Okay. Now, osteocalcin synthesis is stimulated by something, vitamin D. Okay. Calcitrol is the term. I'm not sure if you have learned this in your previous nutrition. So calcitrol is the active vitamin D, which is also considered to be a hormone. So both vitamin A analog, which is retinoic acid, we won't talk about vitamin A, and vitamin D plays a role in the synthesis of this protein. Okay, now the important part is here, which we will have a diagram to show you. There are 3 GLA residues. GLA refers to glutamate, the amino acid glutamate, on the protein, which will facilitate the binding of calcium in the hydroxyapatite. So you may not understand this sentence, but when I show it to you in a subsequent slide, then you will know better. Okay. So the important thing for you to remember first is that there is a protein which is formed in osteoblast called osteocalcin. This osteocalcin, okay, has some glutamate acid residue which will tend to bind calcium. Okay. Now, so if you try to put things together, the first thing is that we need calcium. Why do we need calcium? Well, the calcium will strengthen the bone. So how are we going to get the calcium to better attach and glue to the bone materials? And that is through this mechanism in which the protein, this protein plays a role. Okay. Now, so if we see this diagram, remember I said glutamic acid, okay? Glutamic acid in a protein, okay? Only showing you here will be the glutamic acid part, okay? Now, then on this side is the product. And this is called gamma carboxyl glutamic acid. Okay. Now, so what you see here is the glutamic acid. Originally here, you only have 1 COO. Now, you have 1 more COO. So like a Y shape here. And it is this arrangement which facilitate calcium binding. Okay, so imagine this is part of the protein. Okay, this is part of the protein. Okay, and now calcium comes in like that. And of course, calcium doesn't exist as a calcium ion. It is part of the hydroxyapatite complex. So therefore, you are associating the protein with the hydroxyapatite to form the bone mineral. Okay. So that's what I'm saying here. For example, a protein called osteocalcin. Now, the calcium comes in, and because of this, it facilitates the binding. And this process, of course, is the addition of a COO, because here the glutamic acid only has 1 COO, now it has 2. So this is a carboxylation reaction. And so the enzyme, of course, is carboxylase. Okay, now you can see that another information comes in, and that this enzyme is vitamin K dependent. Vitamin K dependent gamma glutamyl carboxylase. Glutamyl refers to the glutamic acid, okay? And it is a vitamin K dependent carboxylase that acts on this glutamic acid residue of the protein, okay? So very important is this vitamin K dependent gamma glutamyl carboxylase, which will make proteins such as osteocalcin. We usually will refer this to GALA protein, and that is because it is gamma glutamic acid residue with 2-CoO protein. Okay, so production of this is vitamin K dependent. Okay, and I put down here, this is an example of post-translational modification of protein. If you, I'm not sure if you know what is post-translational modification. Do you know that or not? Okay. How do we make protein? You make protein because you have transcription, translation, right? So transcription first, then translation, then you end up having a protein. Post-translation means you change the structure of that protein after the translation process, and that is the post-translation process. Okay, because this protein is not coded by any of the DNA sequence. This is the protein that is coded with the DNA message, which makes this protein. So transcription, translation, you make this protein. Then you add a carbon dioxide COO to it. So that is what we call post-translation. After that protein is formed, you make additional changes so that it becomes like this. So that's why I'm saying post-translational modification of protein. Okay? Yeah. Okay. In fact, later on you will see what I mean. This is also a osteocalcin protein. Only that this one is not carboxylated, and this one is carboxylated. Both are osteocalcin. You can consider it that way. Okay. So we have the genetic code to make osteocalcin. Then after osteocalcin is formed, then we can use this post-translational modification to make this osteocalcin, which is carboxylated. Yes.
Not only one type.
Well, osteocalcin actually, okay. Actually, there are many proteins that will be added on by this carboxylate process. Osteocalcin is only one of the examples that I'm showing you that relates to what we are trying to focus on. So for your purpose, let me just simplify it further. In relations to bone, okay, then we are only highlighting one protein, which is called osteocalcin. We have the genetic information to make this osteocalcin. After this is formed, we can, to different degrees, add COO to it, okay, forming this carboxylated protein, okay. But still, your body will still have osteocalcin, which is not carboxylated. Okay, so you have the original protein, then you have the carboxylated protein. Okay, both exist in your body. That is a good point, good question, because later on we will talk about carboxylated and uncarboxylated osteocalcin. So any problem, any confusion? So let me just repeat again. Your body, of course, make different proteins. Osteocalcin is only one of the proteins that we are talking about in the bone. You can make osteocalcin, and then after you make the osteocalcin, then you have the option to add COO to it. Okay, so that is an option. And the amount of COO added to it, of course, will be depending on many factors. So your body will have the original osteocalcin and the carboxylated osteocalcin. What is the usefulness of the carboxylated osteocalcin? It's because it facilitates calcium binding. Okay? Clear? Okay, good. Yeah. Yes. So your genetic sequence will determine to make the osteocalcin. Yeah. Then adding COO to it is just modifying that protein so that it will better bind calcium. Yeah. Okay, so one of the factors will be that it will bind calcium, and calcium, of course, is not just the calcium ion, it's the whole structure of the hydroxyapatite. Okay. What? Osteoblast. This you remember on the bone cell. Secreted by osteoblast. Your osteoblast is the cell that make bone material. Okay, so this is the machine. Okay, you can call it, which will piece different things together. One will be that it has the enzyme alkaline phosphatase. It will also have the ability to make the osteocalcin, so that when you have the hydroxyapatite, when you have the osteocalcin, you just put things together. Okay. Now, so we just touch on vitamin K because it is a vitamin K dependent enzyme, right? Don't worry about the structure of vitamin K, okay? It comes in different form. Phytoquinol will be the plant form of vitamin K. And then menoquinol will be the animal form, okay? But as long as you remember phytoquinol, menoquinol, that is fine. Menodiol is a chemical structure. This is synthetic, okay? So plant source, animal source. You get vitamin K from a variety of food, and so a lot of the green leafy vegetables contains vitamin K. So I want you to at least remember one or two, okay, of the vegetable. Now, down here is something that I want you to highlight. Vitamin K is essential for what? For blood clotting. I hope you learned this in your nutrition or physiology. However, those at risk of thrombosis and are on anticoagulant therapy would need to monitor vitamin K intake from food. Now, I'm not sure if you understand this part. Thrombosis is Husan. That means you have blockade of your blood vessels. And for these patients, then sometimes they are given aspirin or anticoagulant. Anticoagulant is what? Is for you not to clot blood so easily, right? But vitamin K is what? Its role is to make the blood clot. So they are opposing to each other, okay? So that's why certain people, they have to, if they are on anticoagulant therapy, they have to avoid taking in the vitamin K rich food. Okay. So anticoagulants such as warfarin would be one of the common name for anticoagulant therapy, may also weaken bone. Okay. And that is again referring to the people who are taking the anticoagulant therapy because this is anti-vitamin K, and therefore they may have a decrease in carboxylation. Okay, but this is a rather controversial and more recent observations. I just want to indicate to you. Okay. Okay, so now let's look at age and bone calcium. Okay, and then of course we are going into the osteoporosis part, and we will go through it rather quickly because I'm sure you have that information in your previous nutrition course. So the aspect, of course, is that we have a maximum amount of bone mass, okay, while we still be able to accumulate bone mass. So if you look at the age aspect, in this case, 2 or 3 time phase during the active period, then you lay down bone, and then there is a more or less a balancing stage, and then you have a bone losing stage. And of course, osteoporosis refers to the disappearance of the bone mineral material, including the calcium, and so you have the so-called porous bone, and that individuals will also have shortening of their height due to the weakening and then pressing of the spinal cord. So what you see here is just illustration of a female who can in fact lose about 6 inches between the age of 50 to 80. Now, don't worry about this part. This is the, I hope you have seen it before, but if not, then it is important for you to appreciate. And that is the x-axis is age. We don't start with 0, we start with age 30. Now, why we start with age 30 is because presumably in generally, or it is generally accepted that around 30 years of age, you don't gain any more bone mass, okay? So this is the starting point for this diagram. And then the y-axis, of course, is the bone mass. And then you have the 2 shaded area. One is when osteoporosis happens, and then the other one is the so-called danger zone. So imagine you have 2 individuals, woman A and woman B, okay? At age 30, woman A has this much bone mass, woman B has this much bone mass at the age of 30. Then they go through the aging process, okay? Presumably, in this case, at the same rate of decreasing your bone mass, okay? And then at menopause, which is a decrease in estrogen, because estrogen is playing a very important role, then both of them, the speed of losing bone increase. So this one, woman B, will hit the critical point much earlier, sooner than that of woman A. Woman A start out with more bone mass, will maybe having another 10, 20 years before she hits this critical point, whereas the woman with less bone mass will presumably hit this danger zone at an earlier age and therefore at a high risk of osteoporosis. Okay, so this is the key point of the diagram, making sure that you do know that you should try to gain as much bone mass when you can. And of course, the current method is the dual energy X-ray absorptiometry, which is called DEXA, okay, to determine your bone mass. But the DEXA also can determine your other bone composition, your body composition as well. So in general, mostly it's type 1, okay. Then it is trabecular bone, which is losing more, which is usually the menopausal onset osteoporosis. Senile osteoporosis applies to both men and women. Still, women is more, but you can see the ratio, which is much more for the type 1, okay. Now, so main mechanism for development of osteoporosis could be increase in inadequate peak bone mass, excessive bone resorption, okay, inadequate formation of new bones, etc. Now, so if you look at our whole skeleton, there are areas, okay, bone types, okay, in different parts of the body which has higher or lower amount of trabecular bone. So remember, trabecular bone is the bone type that is losing more in the postmenopausal type of osteoporosis. And so that's why, okay, hip fracture, okay, and the vertebrae will be the most affected one, okay. 95% is trabecular bone, 45% is trabecular bone, okay. So this is just a summary from one of the textbooks indicating to you the risk factor for osteoporosis. So in fact, Asian are so-called the risk group, okay, female, estrogen deficiency, lifetime inadequate intake of calcium and vitamin D, and chronic kidney disease has been associated with osteoporosis. And then protective factors would be not smoking, moderate consumption of alcohol, regular exercise, weight-bearing exercise. That's why promotion of weight-bearing exercise among the elderly has been very important. Now, and of course, we don't use diuretics to try to protect against osteoporosis. You use diuretics only when you have, in this case, generally speaking, high blood pressure. But this is one of the factors that may reduce the risk of osteoporosis. So again, when it comes to diet, so calcium intake for Hong Kong people in general, 400 milligrams. If you drink milk, even if for those who drink milk, usually they don't drink a whole lot. So this has been some studies that we carried out many years ago, showing you the average intake of calcium for non-drinker and drinker. And so you can compare with that of the RDA. This is relatively speaking older. More recent one will be somewhere around 1 to 1.1 gram. And so again, for Hong Kong or Asians in general, their dietary intake is much lower than that of the RDA. So these are some of the key factors for individuals with risk of osteoporosis and why, okay? So it is related to change in calcium metabolism. So a change in calcium metabolism could be increase in calcium loss in urine, increased resorption, that means breakdown of your bone, or decreased calcium absorption. So all these three, or either one of them, could change the balance in the calcium in your body calcium and make it at a high risk of losing more bone mineral and therefore increased risk of osteoporosis. Now, so why you may end up having this kind of situation may be related to, again, the calcium, of course, always tie in with vitamin D. Because calcium absorption is influenced by vitamin D, and also calcium, blood calcium homeostasis is affected by vitamin D. So the reason for this could be, one will be decrease in calcitrol formation. Calcitrol is the name of the active vitamin D, 1,25-hydroxy vitamin D. We will talk about vitamin D after the break. Abnormality in the calcitrol and vitamin D responsive element interaction. Okay, so it is basically the interaction between vitamin D and the receptor. Okay, that may cause the problem. Vitamin D receptor. Yeah, vitamin D receptor. Yeah. Diuretic is for increasing your sodium excretion. But one of the side effects of the diuretic is that it will decrease calcium loss. But that's what I'm saying. You know, you don't purposely take diuretics to protect yourself from osteoporosis. It's just a side effect of diuretics. Okay. Now, so as we said, estrogen plays a key role in osteoporosis or in the onset of osteoporosis. Okay, and of course, certain individuals may then therefore opt for estrogen replacement. But this, of course, is something which is important for you to consult with the doctor, because estrogen replacement has been associated with certain types of cancer risk. So this is a question mark, and therefore, again, for those who are having osteoporosis at around menopausal age, okay, if they are thinking of estrogen replacement, then they should seriously consult with the doctors first, with the expert first, before they do that. Now, the role of estrogen is because estrogen somehow plays an important role in the way that vitamin D interact with its receptor. Okay, as one of the function of the estrogen. Okay. Okay, so we'll stop here, and then we will talk about this bariatric surgery and how it impacts calcium absorption after the break. Okay, so if you have questions for the first half of the lecture, you can always ask. And again, for those who come in late, the ethic approval for some of the students are here, so you can pick it up. So 10 minutes break. Okay, now, so we just provide you with a perspective, telling you that, okay, taking calcium is important, but age is a factor, and particularly for female, postmenopausal effect, which is related to the hormone estrogen, and so on and so forth. Then now we will go into some situation which will affect calcium absorption and therefore increase the risk of bone fracture. Now, so remember in the previous lecture, we refer to a terminology which is called bariatric surgery. Bariatric surgery in general are referred to highly invasive surgical method, okay? Such as, in this case, so-called gastric bypasses that will decrease the area of nutrient absorption for the sake of helping the morbidly obese individuals to reduce the amount of energy to absorb so that they can lose weight, okay? Now, there are many variety of surgical procedure, but as I said, so I would like you to remember the terminology, which is bariatric surgery is just a general term. Now, so this is just some of the example, okay, of bariatric surgery. One is that you basically remove part of the stomach. Roux-en-Y is a common surgical procedure. Again, reducing the digestive and absorptive area so that you end up absorbing less nutrient and energy. So the food goes in here, very little space for it to digest and store the food. So the subject will get full or will feel full very soon, and then those food will go right to here for absorption. So in the previous lecture, we say, okay, this will therefore reduce the amount of area of absorption, leading to, for example, vitamin B deficiency. Now we are talking about how it affects calcium, okay? So this is just a study, and I will explain it to you, and I only highlight a few points. Intestinal calcium absorption, anthropometric calcium homeostasis, and skeletal parameters before and 6 months after Roux-en-Y gastric bypass, okay? So you have the pre-operative individual and 6 months after operation, okay? Now, of course, the individual will lose weight, okay? Before surgery is 125 kilo, now it's 93. 93 is still quite a lot, but I mean, compared to the original, it's already reduced. But I want to, because we are talking about calcium, so this is the calcium information. Fractional calcium absorption, this is an indicator of to what extent calcium is being absorbed. Okay, so this is just a value as a result of the research. So before absorption, before the operation is 33% calcium absorption, and now it's only 7%. So daily calcium absorption is down to 82 milligram versus almost 400 beginning, okay? So highly significant impact. And of course, this change is basically due to what? Decrease in the digestive and absorptive area, as shown in the previous slide. So now, what is the impact on overall bone health? And that is what is shown in here. And I want you to remember this terminology, CTX. So CTX is called C-tertiopeptide. So this is a biomarker for bone resorption. So what is bone resorption? Bone resorption is what? Is breakdown of the bone mineral content. That is resorption process. Okay, so what you can see is the CTX value is say 0.3 here and almost 1, indicating that the post-operation you have a more or less 3 times higher in terms of the rate at which your bone is demineralizing. Okay, so again, this is a important aspect, and therefore for those people who are into this kind of bariatric surgery or any type of surgery that will affect the digestive and absorptive area will also again impact not only as what we said earlier, B vitamin, but also in this case, the example is calcium. So what you can see here is from the same, from another study, I think, post-operative fractional calcium absorption, and then change in the this biomarker of bone resorption. So the high bone resorption is associated with what? Low calcium absorption, okay, which is of course consistent with what you see here, okay. Now, so what is the consequence? Why would this happen? Why you have increase in bone resorption? Is because, as I have underlined here, after the surgery, impair intestinal calcium absorption, threatens serum calcium concentration. That means it may drop, it may cause the concentration to drop, and therefore the hormone PTH secretion increase. PTH enhance renal calcium absorption or reabsorption, stimulate conversion of the 25 to the hydroxy 125 hydroxy. Now, you may not truly understand what I mean here, but don't worry, because we will have a detailed diagram for you later on. So this is the more or less the focus. So you have a normal situation, and then after the bariatric surgery. So the triggering point is decrease in calcium due to decrease in absorption, and therefore it will trigger a sequence of events. That sequence of events include increase in parathyroid hormone, PTH. Now, again, we are just highlighting here. We will have diagrams, more detail later on, okay? Which will trigger a sequence of events, including demineralization or resorption in the bone, okay? And also decrease in kidney loss, so as to jack up or increase calcium concentration in the blood. So this is a simplified version of the calcium homeostasis. We will have a detailed diagram later on, okay? Another situation here, elevated diabetes risk in women with high serum calcium. Now, you always think that we don't have enough calcium. So how come you have this? Now, this is getting complicated, okay? We don't know exactly the mechanism, but there are more than one study. There are actually many studies relating just blood calcium. I'm not talking about bone calcium, okay? I'm talking about blood calcium. Elevated diabetes risk in women with high serum calcium, okay? So what you see is, this is men and women, okay? Calcium group, okay? Low, medium, high, okay, low, medium, high. And this is insulin resistance. So what this table says is level of fasting serum glucose, insulin, insulin resistance, and beta cell function in low, medium, and high serum calcium. So what you see here is high calcium, okay, group, okay, compared to the low calcium group, okay, a high significant difference, okay. Now, so if you move to here from the same study, okay, comparison between low and high serum calcium groups of women adjusted for vitamin D and PTH. So now you have adjustment as well. So you are eliminating the confounding effect of vitamin D and PTH. So low calcium, high calcium group. Okay, high calcium group, high glucose, insulin resistance. Okay, so altered calcium homeostasis. Now, whether it is vitamin D related, we don't know. It's associated with abnormal glucose disposal and reduced insulin sensitivity. So this is the bottom line. Now, you think that this is a single case report? In fact, it's not. So over the years, there are many studies reporting this association. We don't know why, okay? But this is one of the recent report, and this is a Taiwan study. Again, association, okay? So I caution that association is a relationship. So we don't know what is the cause, what is the effect. Maybe it is diabetes that cause high calcium, or maybe it is high calcium cause diabetes. We don't know. But what you can see is this study, the result is basically the same as the previous one. So what I'm just highlighting with the yellow one, okay? So people with metabolic syndrome, diabetes, hypertension. Now, so what you see is, in general, the significant thing are more significant in a female. And the previous study is also on a female. Okay, so metabolic syndrome, okay, here, diabetes, here, whether you are using statistical model 1 or 2. Model 1 or 2 are just adjusted for different confounding factor, hypertension. So, for example, if you look at female here, all different situations are highly correlated with a high serum calcium. So again, we don't know what is going on, okay? And as I said, I caution, there's no cause and effect established. So this is just again, don't memorize it. Okay, don't memorize the diagram. I just highlighted. I haven't put it in the handout, but this is, I find it too small to read, so I just select a few things for you to remember. So somehow, how diabetes will interact with different organs, and since we're talking about bone, so I'm just highlighting here, okay? So somehow the diabetic situation may cause the bone forming cells apoptosis to increase, or to speed up the bone breakdown cell activity. So you have increase in bone resorption, or impair in collagenase synthesis, etc. So these are some of the possible answers, okay, for a relationship between diabetes and calcium. And because bone contains most of the calcium, that's why it is related to the bone. But again, a lot of research is needed for us to better understand what is going on. So interaction with other nutrients. High sodium intake is known to increase calcium excretion. Okay, So if you take in a high sodium diet, you lose more calcium. As I said, caffeine will increase calcium excretion, but in general, this effect is not that significant. Okay, yes, it will increase, but it's not a very important impact. Then we will talk about calcium-phosphorus interaction later, and that is referred to the other slide, which is number 60. And for this one, this is just something for you to know, because we are not going to have enough time to spend on it. So if you are taking calcium supplement, okay, in the form of calcium carbonate, then it will decrease your LDH cholesterol and increase HDL cholesterol, okay, which presumably is good, okay. Now, then we turn to phosphorus, okay, and phosphorus, we are going to touch on it very quickly because we only focus on the interaction between calcium and phosphorus. Now, of course, phosphorus is an important component of the hydroxyapatite because if you look at the hydroxyapatite formula and calcium and phosphate, okay, this is the food source, which again I won't spend time on. The high phosphate food will be, in this case, the dairy products, okay, as well as some seed and tofu, and then the liver, which will be quite high. But most of the phosphorus comes in processed food, okay? So soft drink, for example, contains about 25 to 40 milligrams. So the concern is that we take in too much phosphate, okay, which primarily will be from processing food, and also the phytic acid, which is present in the phytate, which is present in certain food that will interfere with that of the absorption of other nutrients. Now, the diagram here, I don't want to spend time on it, but this is what I want you to remember, and that is that our body phosphate balance is basically dictated by excretion, okay? So renal excretion plays a key role in regulating body phosphates. That's the key point that I want you to make. And therefore, kidney disease and renal failure will increase serum phosphate and decrease serum calcium, okay? So that's why people with kidney problem, okay, will also have bone problem, okay? So this is the only thing that I want to highlight, and we don't have time to spend going through the clinical aspects of chronic kidney disease. Now, so this is from a nutritional standpoint, potentially the impact of an imbalance between calcium and phosphorus. Now, I'm highlighting this to you, but this point is debatable because there are people who agree and there are people who disagree with it. Okay, so what's showing here is the time in weeks. Okay, and then you have the y-axis showing you is the concentration of a hormone, which is called parathyroid hormone, PTH. Now, parathyroid hormone is a hormone that regulates calcium metabolism, which we will talk about in a minute. So what you see here will be two subjects. First one, these subjects start with a 500 milligram calcium and 1 gram phosphorus. Okay. Then what at week 6, the calcium intake is maintained at 500 milligram, but then he will double the phosphorus intake. So what you see here is a drastic increase in serum PTH, okay? Simply because an increase in phosphorus intake. Here, another subject, okay? He start off with 1 gram, 1 gram, both 1 gram, okay? And then at week 6, again, he increased the phosphorus intake, but maintained the calcium intake and again, you see a increase in PTH. Okay, so PTH obviously will increase in response to dietary phosphorus intake. So that is a key observation. Okay, now whether this increase in phosphorus intake over long term will influence your bone mineral content is another issue that needs to be established. Okay, but since PTH is responsible for demineralization, so this is the implication that if you have high phosphorus intake, then it is not good for your bone health. Okay. Now, then the other side of the story is, what about if we increase calcium intake? You can increase calcium intake by increasing food calcium, okay, or by supplementation, okay. So some of the issues that are associated with increased risk, for example, kidney stone, increased risk of cardiovascular disease, increase in calcification of blood vessels. So these are some of the so-called concerns of calcium supplementation. That means you take in calcium pills instead of increasing calcium through increase in food consumption. Okay, but again, these are rather controversial stuff. Okay, because there are positive and negative studies done, and also it depends on the amount of calcium that is being taken in, population subgroups, etc. So this is still controversial issues related to whether calcium supplementation is good or not. In general, of course, if it is too high, then obviously it will put a more higher risk. Okay, but if it is a low supplementation level, likely that it is not going to have this kind of effects. Now, so this is one of the reasons why you will see some interesting recommendation. That recommendation is from U.S. Preventive Service Task Force, and it was just a few years ago, talking about calcium vitamin D supplementation. So I just summarize some bullet points here. Current evidence is insufficient to assess the balance of the benefits and harms of daily supplementation with doses greater than 400 international unit of vitamin D and greater than 1 gram of calcium for primary prevention of fractures in community dwelling postmenopausal women. Recommendation is against daily supplementation, but do not apply to those with a history of osteoporosis fracture, increased risk of fall or diagnosis of osteoporosis, etc. So again, they are quite concerned about taking in too much. Okay, so we are talking about supplementation of more than 400 international unit of vitamin D and supplementation of more than 1 gram of calcium. Okay, remember our RDA is around 1 gram. So they are talking about, they do not recommend using that level. Okay, but again, this is USA. If you remember, in United States, dairy product is popular, whereas in Asia countries, then dairy product is not as popular, and our calcium intake in general are lower than that of from food. It's lower than that of in the Western countries. Okay, effects of calcium or body functions are closely related to vitamin D. So that's why we are going to talk about vitamin D, and I'm sure you are quite familiar with some of the effects of vitamin D in your nutrition course. So we are only going to highlight some of the information which is new to you. Okay, so of course, Ricus another chicken breast, etc., are typical example of vitamin D deficiency and or related to calcium. And we know that vitamin D is important, and from the perspective that we be able to obtain vitamin D by exposing ourselves to ultraviolet radiation. So what I want you to at least remember, and you should already know this, is what is cholecalciferol, what is 25, and what is 125. Okay, so in our skin, we have enzymes which will convert 7-dehydrocholesterol to the pre-vitamin D3, and then turn into vitamin D3, which would then get hydroxylated in the liver and then in the kidney, 2 steps of hydroxylation to eventually get you the active form of the vitamin, which is called calcitrol. Okay, so what I would like you to know is, well, 1,25-hydroxy D is calcitrol. 2 steps hydroxylation, once in the liver, one in the kidney. Okay, and you have this process which happens in the sebaceous gland in your skin. So this is just a diagram, which again, I won't spend time going through, and that is describing to you how we make vitamin D, and then vitamin D may play a role in different biological systems. Now, highlighting here is vitamin D status is closely linked to many diseases, including diabetes, respiratory tract infection, and certain cancers. And this will be something that we will spend a little bit time talking about later. Okay. So this is just a repeat of what I just mentioned in the diagram. Okay. So there are important locations that you need to remember: the liver and the kidney for hydroxylation, and the 1,25-hydroxy D is calcitrol. So again, you don't need to memorize the structure, but you should be able to be familiar with the name. Okay, so we can have vitamin D either from the skin through exposure to the sun, or you can get some vitamin D from the diet. Okay, ergo calciferol will be the from the plant source. Okay, now, so what we need to remember will be the 1,25 dihydroxy D, and down here will be what we will be focusing on in the next few diagrams, and that is the 3 organs that play a key role, okay, in controlling calcium flux or calcium metabolism that relates with vitamin D and the parathyroid hormone. Okay, this is just the same diagram that we a different diagram, but showing you the same information regarding how we eventually get the active vitamin D, and that is 1,25-hydroxy. So 1,25-hydroxy, okay, as mentioned, okay, will act on different organs. Okay, and the 3 organs that we are focusing on will be intestine, bone, and then the parathyroid hormone, the parathyroid gland. So this is the diagram that I want you to remember if you haven't learned this in your previous nutrition course. So we have the parathyroid gland. Now, make sure you don't mix up with thyroid gland. Okay, thyroid gland is different from parathyroid gland. Okay, thyroid gland makes thyroid hormone. Parathyroid gland makes parathyroid hormone. 2 different tissues, 2 different hormones. Okay, so this is parathyroid gland, intestine, kidney, and bone, and that is your blood vessels representing the concentration of calcium in the blood. Okay, so assuming that we have a drop in calcium in the blood as the initial signal. Okay, so that is the important aspect. So step one, initial stimulus. Now, as I said, we have the ability to tightly control your blood calcium. We show it to you in the previous slides. So in the event that there is a decrease in calcium, so when the calcium concentration deviate from the normal level, then it will trigger the parathyroid gland, which has a sensor that detects calcium concentration in the blood. So this decrease will trigger the parathyroid gland to make and then release more parathyroid hormone, which is PTH. Okay, the PTH goes into the blood and will act on two organs, kidney and the bone. Now, so we talk about the kidney first. Increase parathyroid hormone in the blood, act on the kidney. What does it do? Two things. Stimulate kidney to increase calcium reabsorption. Okay, pretty straightforward. And then, more important, stimulate the kidney hydroxylation of 25 to the active hormone 1,25-hydroxy-D. Remember, 1,25 is the active vitamin D hormone, okay, which is calcitrol. So PTH, in response to a drop in calcium, is important step. So now we decrease the renal loss by increasing absorption in the kidney. Therefore, we'll increase blood calcium, right? We make more 125, which will then act on the intestine to increase calcium absorption. Okay. Increase calcium absorption, therefore also will increase blood calcium. Now, then PTH also act on the bone. Increase PTH together with increase in vitamin D act on the bone and stimulate resorption. That means breakdown of the bone. Breakdown of the bone will release the calcium and phosphorus, and therefore, again, try to correct the original problem, that is a decrease in calcium. So you have a number of ways to increase blood calcium, increase absorption, decrease renal loss, increase demineralization. So all three responses will try to correct the problem, the original problem, that is a decrease in calcium. Okay, so this is the big picture that connect calcium, PTH, and vitamin D. Okay. Yep. Yeah. But our body phosphorus, as I said, is controlled mainly by excretion. So when you have increase in phosphorus, you also have most likely increasing phosphate loss in the urine as well. Okay, so vitamin D, again, the key things that for you to remember will be 125, okay? Now, then hydroxylations can be occurring on the other locations. For example, instead of 125, you can have 24, 25, etc. But this is not the active hormone, so to speak. Okay. So through this, if you add another hydroxy group at the 24 position, you end up getting something called calcium acid, which is not active. So function of vitamin D, many, okay. I just want to highlight, for example, in our later discussion, for example, insulin effect, because it can take several more lectures to just talk about how vitamin D is related with our current health situation. So vitamin D, we consider this as a hormone. Its mechanism is acting like a steroid hormone, okay? So it will have a genomic effect, okay, affecting transcription and then eventually translation. This is just a diagram showing you the typical structure of vitamin D response element and how it will respond to the impact of the vitamin D as well as vitamin A. The whole thing needs both vitamin D and vitamin A in the form of retinoic acid for triggering the response element. But again, I'm just providing you with a perspective. We are not going to go into detail. So for example, vitamin D is needed for calcium absorption, right? So why is it happening? Okay, so if you have vitamin D here, okay, so this is the blood side, okay, you will then impact and then have the calcium binding protein, which will then bind the incoming calcium and then release them into the blood, okay? So the calcium binding protein, in this case, is called calbindin, plays a role in moving the calcium across the enterocyte, okay? Now, so vitamin D, our standard will be somewhere around 400 international unit. And when we say international unit, then you can also convert it into microgram. So it's 1 to 40, okay, in terms of the conversion. You can see that US RDA and Chinese RDA are more or less similar, only that for them, anyone who is above 70, then their recommendation is higher. Okay, now again, it also depends on the food source, and different countries would have a different degree of vitamin D addition or fortification into milk. So that's one of the aspects that you have to realize. Oh, okay. The typical standard assessment is to measure 25-hydroxy-D, okay, not 125, okay. So it's measuring plasma concentration of 25-hydroxy-D, and you will see this again later on. Now, this is something that is related to sun exposure. I'm sure you know that ultraviolet radiation is important for synthesis of vitamin D, and that occurs in the skin. Now, so the problem is there is a very high prevalence of vitamin D deficiency. Okay, much higher than expected, and I'll show it to you later. The negative factor affecting vitamin D status may be inadequate intake, dietary intake, staying indoor all the time, and overprotection, either clothing or use of sunscreen. And then you will have this latitude effect that I'm going to explain to you, okay? Overprotection, too much sunscreen. When you have sunscreen that has a sun protective factor of say 15 or more, then you basically block out majority of the UVB. And a sunscreen factor of 15 already will cause a reduction in the formation of the precalciferol by 99%. Okay, so applying sunscreen all the time, okay, is one important factor. And then the other factor will be sun exposure. Okay, sun exposure is affected by time of year and location. Exposure is reduced during winter time, okay, when day is short and night is long, as well as reduced with increase in latitude. Increase in latitude means the further north you are, okay, from the equator, or the more you are closer to the north or south pole, then again that will have an impact. So what you see here is, again, depending on your skin color, then you will have, when you expose to the sun, you will have different degree of tanning. If you have a pale, okay, skin color versus the black people, which is much darker, okay, then the different degree of blocking of the ultraviolet radiation, therefore related to vitamin D synthesis, will change. So you will see that vitamin D synthesis will be much greater in the fair-skinned people compared to the dark-skinned people. And this is why, say, for example, in this statement, a good 40% of the African American women in USA were deficient at the end of the winter. Remember, I say season and location will determine how risky you are in terms of vitamin D deficiency. So now adding on will be the skin color. So black women, okay, who live in the winter time, living in North America, probably is the worst scenario. Okay. Now, this is the latitude effect. Before we say 30 degrees, now sometimes we say 40 degrees latitude. So what is this? The upper north you are, the lesser sunlight you receive, and the longer the winter time. Okay. And so this is what usually we say, either 30 degrees latitude effect or 40 degrees latitude effect. Usually we say 40 degrees latitude effect, but now some people say even 30 degrees is also having an impact. So you can see that Hong Kong is down here, okay? Shanghai, Beijing, London, Sydney. Sydney, of course, is the South Pole, a Southern Hemisphere. Now, of course, you have the vitamin D in with various functions, not only the bone, but in a variety of biological effects, including immune functions and cell growth, etc., that we don't have time to go into. What I want to highlight to you is the effect of sun exposure and cancer mortality rate. Okay. Now, remember, what I'm saying is not mortality due to skin cancer. Very often, people will immediately think of skin cancer due to sun exposure. I'm not talking about cancer mortality due to skin cancer. I'm talking about total mortality, okay? Total mortality. People live at higher latitude, face higher risk of many chronic diseases, and that is well established, as well as a higher rate of mortality. So this is the important information that I want you to get. Y-axis, this is A and B, will be men and women, okay? Mortality rate, that means death rates. Mortality rate due to all types of cancer, okay? Not just skin cancer, okay? All types of cancer. What is the relationship? Inverse. What is y-axis? Y-axis is sun exposure, at least monitored as UVB exposure, okay? So if you have less, mortality is high. That means the less exposure you are to sun, the higher the risk of chronic diseases and the higher risk of mortality due to chronic diseases. Okay? Remember, not skin cancer alone, okay? Total, all sorts of cancer, okay? And this is a fairly well-established relationship. So the argument is, well, many of you use sunscreen, want to get white, okay, not dark. Is it good for you? Now, so vitamin D, I just said there is a wide spread of vitamin D deficiency. And for the subsequent slides, I'm just showing you that information, okay? So it is very easy to digest. Now, I said that we estimate or we evaluate vitamin D status usually by measuring 25-hydroxy-D, okay? So this is the so-called accepted cutoffs. Optimum level, okay? We say optimum level, between 20 to 50, depending on which unit you use. Now, so you will see I use both units. I showed you both units. So the conversion is just multiplied by 2.5 if you're using nanogram versus the nanomole, okay? So 20 times 2.5 is 50. So again, I just want you to focus on this, what we call optimum. The optimum range presumably is 20 to 50. So that means this will be the lowest value for optimum range, okay, that we are now accepting. And also this is the level that is being questioned now, okay, whether this is too low, okay. And of course, the vitamin D conditions will have serious consequences. Prevalence, and this is 10 years ago, okay, prevalence and correlates of vitamin D deficiency in US adults. Multivariate analysis showed that being from a non-white race, not college educated, blah, 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 okay? Independently associated with vitamin D deficiency. Vitamin D deficiency was defined as vitamin D less than 20, okay? So this is what we call the cutoff point, okay? Overall prevalence rate of vitamin deficiency was 42%, okay, in US. This is a in Chinese student, Chinese children, okay, 5 years ago. Median 25-hydroxy-D, 19. Remember, 20 is the cutoff. So the median is lower than the cutoff. A deficiency cutoff of 50, or that the male and female have somewhere around 50%. So this is consistent with this one. This one is 42. In China, some of the children is around 50%. Okay. In Hong Kong, okay, this is 7 years ago. Mean values in all age groups in spring. In spring, that means time when we have less sun, okay? Below 50. This is nanomole, that means below 20, okay? So the mean value is below 20. Now, this is relationship of vitamin D with that of all cases of mortality. 死亡率. Okay? So So this is the mean. So this is the upper and lower 95 percentile. Now, if we use 20, okay, which is the current cutoff. Remember, anything below 20 is no good, and the so-called optimum is between 20 and 50. But if we draw a line here and then go across, that means at the 20, then the all causes of mortality will be higher, okay? Even at this level of 20 that we now accept, okay? And in fact, if you look at the people who are living in areas which has lots of sun, this is done in Hawaii on some surfers, male and females, and look at their vitamin 25 hydroxy D level. The mean is only 30, okay, and a good 50 equals 20, right? 20 nanogram. So a good 10% is below the 20 that is the cutoff. But if you use 30, okay, if you just move the cutoff here, then a good half of the surveyed subjects are lower than that of the cutoff value. Now, the problem associated with vitamin D status has been a lot, okay, and I'm just highlighting this to you. It is quite well established that plays a role in prevention of acute respiratory tract infection. Okay, now we are not going to show you the detail here, but just to point out that before COVID, we already know vitamin D prevents acute respiratory tract infection. Okay, this is triggered by COVID, and it was found. Now, just for your information, the SARS virus, okay, one of the impact of the SARS virus is that it will inhibit an enzyme, okay? It will inhibit an enzyme which is called ACE2, okay? ACE is a angiotensin converting enzyme 2. Now, what is the consequence of inhibiting this enzyme? It causes a decrease in angiotensin 2 to angiotensin 1, and angiotensin 2 can result in inflammation, apoptosis, etc. Now, vitamin D in its active form actually increase ACE2. Okay, so that's why, because of the prior information that vitamin D plays a role in acute respiratory tract infection, people start to look into the COVID subjects and whether they are vitamin D deficient, because vitamin D presumably will act in the opposite way of the virus in terms of the ACE2 activity. Okay, so of course, then you will see that there are reports indicating that there's association of the vitamin D deficiency and mortality. So that means the worse off they are, the higher the mortality in the COVID subjects. And this is a study just done 2 years ago, indicating that those with 25-hydroxy-D supplementation versus those without the 25-hydroxy supplementation, the incidence of the need to go into ICU are different. Okay, so this is a considered to be a positive effect of vitamin D. But this study say there is no effect of vitamin D. Okay, so there are different reports. But given that the vitamin D has no adverse effect, so the recommendation has been that, well, it probably does no harm, even if it doesn't work. Okay, so this is what what I highlight in here for this particular, for a point for you to draw, okay, attention to. Of course, the problem is that vitamin D is associated with so many different body functions. So it is very complicated to just simply try to highlight and single out vitamin D and how it will be playing a role in situations such as COVID mortality, because the people who die of COVID, sometimes they also have other chronic diseases. Okay, and so therefore very difficult to tease out. Now, so we now then go to some even more complicated issues relating diabetes with vitamin D and bone metabolism. Okay, now, so I just finished with the COVID, so don't worry about the COVID now. So we move to an area which is vitamin D and diabetes. Okay, again, fairly complicated, and we don't have all the answers, but I think it will be useful for you to at least know that something is there, and that is also important. Now, let's focus on this diagram first. Okay, don't worry about the wordings. So this is osteoblast. Okay, osteoblast. Osteoblast is what? The cell that makes the bone. Okay. So you have vitamin D, add on it, so that you have the calcium, and then you have vitamin K for what? For carboxylation. For carboxylations to make carboxylated osteocalcin, right? Now, but I say in your body, you start off with your genetic material to tell your body or the cell to make osteocalcin. Then you have the options to add COO to the osteocalcin so that it will be carboxylated. So your body have two types of osteocalcin. Uncarboxylated osteocalcin, that is the original protein, and then the modified osteocalcin, that is the carboxylated osteocalcin. Now, carboxylated osteocalcin is important for mineralization, for bone, okay? But the uncarboxylated osteocalcin has also impact on your body, okay? And it has been studied extensively, and that it will act on various tissues, including pancreas, muscle, and edible tissues. Okay. Now, so if we go through here, the first bullet point is type 2 diabetics is associated with increased fracture risk. So this is a well-established evidence. So type 2 subjects also have high incidence of fracture, presumably more osteoporosis, more fragile bones. Increased risk occur even the bone mineral density is normal or even higher. Okay. T2D negatively affects bone strength regardless of bone mineral density. So somehow the diabetic situation will decrease the rigidity of the bone, and therefore rendering it more easy to break. Okay. Now, so insulin signaling in the osteoblast. Okay, so this is the osteoblast, but we are not showing you the insulin signaling yet, so we will show it to you later. Will have an impact on the process which play a role in making the osteocalcin expression. Insulin also stimulates bone turnover, increase osteoclast activity. So this is one of the factors. When you have osteoclast activity increase, the pH decrease and therefore increase the mineralization. And carboxylated osteocalcin. So UN stands for uncarboxylated osteocalcin. So this is the original osteocalcin. Act on pancreas to induce insulin secretion and on edible tissues to induce adiponectin secretion, which is another hormone. Both effects enhance insulin sensitivity. Okay, so the osteocalcin somehow play a role in affecting insulin secretion. Okay. Now, so before we go to the diagram, this is just to indicating to you what kind of data we have. So relationship between osteocalcin level and glucose parameters in enrolled population, controlled population, and DMT population. So you have the control population and DM2 populations to compare. So what you see here is the relationship between osteocalcin and fasting blood glucose, HbA1c, and HOMA-IR. Okay, so you can see that somehow you have a negative relationship between the osteocalcin and HbA1c. A negative relationship means what? The higher the osteocalcin, the lower the HbA1c, right? Which of course is what you want. But this correlation doesn't exist in the diabetic population. Somehow there is no relationship. Okay, so we don't know why. Okay, there is a lack of relationship. So what you see here is the proposed mechanism. And again, I don't want you to be able to remember the whole thing, but I want you to know that the uncarboxylated osteocalcin that I showed you earlier, okay, here, so we have carboxylated and uncarboxylated. The uncarboxylated osteocalcin can act on edible tissues, act on pancreas, which if it acts on the pancreas, it will have mechanisms to increase insulin secretion, okay? When it acts on the edible tissues is the location where it produces another hormone, which is called adiponectin. And this adiponectin plays a role in changing the sensitivity of the muscle to insulin. So it will promote the muscle response to insulin effect. So the effect of uncarboxylated osteocalcin is positive in terms of glucose homeostasis. Okay. So vitamin D, through the regulation of calcium homeostasis, participate in insulin secretion by the pancreatic cell. So again, we're trying to link calcium and vitamin D, etc. So this is just a proposed mechanism. Enough vitamin D will act. Don't worry about the internal, all these pathways, because we are not going to ask you and we're not going to have time to discuss that. But eventually, what it affects is that it may affect calcium influx as well as influencing the intracellular signaling related to insulin release. So adequate amount of vitamin D is important for insulin secretion. Okay, so summary key point would be vitamin D is important in regulating calcium influx into basal cells. So this is the calcium influx. Vitamin D through intracellular calcium regulation modulates depolarization, stimulated insulin secretion. So it will control and influence insulin secretion. So inadequate vitamin D may therefore interfere with a decrease in insulin secretion in response to the stimulus. So what you see here will be some data, okay? Let's just look at the diagram here. Control versus the diabetics, type 2. Serum 25-hydroxy-D. So the mean difference is lower, okay? HOMA score, okay? HOMA score related to 25-hydroxy-D, okay? So the higher the 25-hydroxy D. That means the higher the level of vitamin D, the lower the IR. Okay. And then this is the negative correlation, 25. So this basically is from here. Inverse relationship between HOMA-IR and 25-hydroxy D. Okay. So T2D subjects exhibit lower serum 25-hydroxy D and negative relationship between the HOMA-IR, that is insulin resistance, and serum 25. Okay. Consistent with this study, results from another study report an inverse relationship between HbA1c and serum 25. So it's consistent with the previous data. The effect of vitamin D supplementation on glycemic control in type 2 diabetic subjects, meta-analysis. Okay, so we are not going to show you the data. Okay, and again, just give you the abstract since we showed you the data earlier. Vitamin D supplementation was shown to increase serum 25D and reduce insulin resistance effectively. Okay, so again, a good vitamin D status appears to be important for people who are diabetic in terms of controlling the glucose homeostasis. Now, so we come to the last, and that is the 10 minutes or so for us to talk about the last of the macro, and that is magnesium. Okay, so we have somewhere around 30 grams of magnesium in our body. Now, we are going to talk about magnesium not from the perspective of bone, but also linked to that of the diabetic situation. Okay, magnesium, majority of them are inside the cell. Okay, and then of course magnesium is required for a lot of biological events because it is important for muscle relaxation, and also there will be enzymes, which is magnesium ATPase dependence. Okay, and then you would have something which we will talk about later, important in phosphorylation of the insulin receptor. Okay, which is the intracellular signaling mechanism. Intake. In general, we are not taking enough, but there's not that much data. Okay, but in general, we don't take a whole lot, but we are not that deficient. Okay, and then you would have a nutritional assessment situation. No easy test for magnesium. You can measure magnesium total or the ionized one, and it is the ionized magnesium that really plays a role in biology. Okay, magnesium in food. So these are just examples that you can remember a few of them. Beans, brown rice, chocolate, almonds, tuna, etc. Okay, avocado, bananas. Now, magnesium and health. Okay, low body magnesium is usually resulted from inadequate intake and reduced retention. That means increase in renal loss. So instead of poor absorption, usually we don't take enough, or we have high renal loss. Okay, that is the usual cause of poor body magnesium status. Suboptimal magnesium status is associated with a variety of situations, including cardiovascular disease, hypertension, T2D, etc. Okay, magnesium and hypertension. Okay, hard water areas with lower incidence of cardiovascular disease. Okay, hard water means public water supply that contains mineral. Okay, so in the area with hard water, the overall incidence of cardiovascular disease is lower, indicating some role of the mineral in the water, which has a positive effect. Magnesium intake has an independent and significant inverse association with blood pressure. Nurse health study is a very big epidemiological surveillance type of study done in North America. So many different papers has come out from this study, and one of them, or a series of this, indicating that there is a inverse relationship between blood pressure and magnesium intake, which of course corresponds to this. Okay, so blood pressure, cardiovascular disease. Increased potassium intake is associated with reduced urinary calcium and magnesium excretion. So again, interaction between the potassium and sodium, and then calcium and magnesium. And now we're going to go into a little bit of detail. Type 2 diabetic and or metabolic syndrome people have lower magnesium level. Magnesium supplementation may benefit those with low initial magnesium level. So we are going to spend a bit time, or the remaining time, on this one. Okay, so this is a meta-analysis done a number of years ago, looking at subjects with metabolic syndrome. So the forest plot, okay, indicating that serum magnesium in subjects with metabolic syndrome was 0.0919 milligram per deciliter less than the control. So metabolic syndrome subjects has lower serum magnesium. So this is what this is what the observation is, and then translated into another issue will be the risk of metabolic syndrome. So higher magnesium intake is associated with lower risk of metabolic syndrome. So again, this is the forest plot for that. Now, so if you look at another study trying to look into magnesium ion and fasting blood glucose, FPG stands for fasting plasma glucose, HbA1c. Okay, so as I said, magnesium, you can measure total magnesium or ionized magnesium, but again, usually ionized magnesium is the key of the magnesium biological effect. So again, you can see inverse relationship. So that means the higher the magnesium level, the lower the blood glucose, and the lower the HbA1c value. Okay. So now what you see here is yet another study just about 2 years ago, relative risk for T2D with 95 percentile. So this is the being a 95 percentile level. X-axis is the magnesium intake. Now, so what is our recommendation? Our recommendation is here, around 400 milligram of magnesium a day. And this is the relationship between magnesium intake and T2D risk. So the lower the risk, the lower the value, the better off you are in terms of risk. Okay, and so what you can see is that it is an inverse relationship. So our recommendation here is here, which basically represents as what you can see with the lowest risk. That means if you take in magnesium at the LDA level, okay, you more or less have the lowest risk. But as you decrease your magnesium intake, your risk of T2D increase. Okay. So some biological effects of magnesium related to metabolic syndrome and T2D. Okay, magnesium, as said, have some impact on the insulin signaling pathway and or insulin secretion. It may affect the GLUT4. GLUT4 is the transporter of glucose. Okay, GLUT4 activity to regulate glucose influx into into a muscle cell. It may also modulate enzymes which are playing a role in gluconeogenesis.